Welcome to the presentation on an overview of the donation process and blood component specification. This presentation will cover the following topics: a revision of the donation process, a review of the most commonly prescribed blood components, the need for blood components with specific specifications for neonates and adults, and will include an overview in blood component compatibility. This table is taken from the Serious Hazards of Transfusion Short Reporting Scheme. The data illustrates how much blood components are used across the UK. Currently in NHS Scotland there is no direct cost to health boards for blood. The Scottish National Blood Transfusion Service are funded from National Services Scotland directly to provide this service. This is not the case in the other UK countries, where individual health trusts pay directly for the blood that is used. Increased regulation and more sophisticated testing, leukodepletion, importation of plasma has resulted in increased costs in recent years. The cost will continue to rise as newer and other safety measures are introduced. For example, the next step is prion filtration as a preventative variant CJD precaution. However, the costs do not take into account the cost and time that the donor has given as they undertake this altruistic act to donate blood. The supply chain is the method of getting the blood from the donor to the patient, and this is a complex and fragile process. The chain linking the donors to the recipients is composed of numerous people and organisations, each with their own distinctive skills that contribute to and have a valuable role to play. One of the major challenges that each of the blood services have is maintaining a donor base. Despite a lot of recruiting efforts, the donor base is continuing to fall in many countries. Only 3% of the adults are currently blood donors, and 50% of these regularly give 75% of the donations. A further 6% of donors will lapse each year. The blood service often experience particular problems in maintaining blood supply during periods of holidays, particularly at Christmas and New Year. The supply chain process is made up from a number of steps. Each donor who donates a unit of blood has to follow a strict acceptance criteria, and as a result of this, they get a free tea and a biscuit as a reward. The blood is processed and tested by the regional blood establishment. In Scotland, this is undertaken by the National Blood Transfusion Service. Then blood is sent out to the local hospitals for use. Delivery of the blood to local hospitals is undertaken by SMBTS and is sent out in delivery vans each day. Hospital transfusion laboratories tailor their stock requirements to individual hospital requirements and will make sure that blood is available for patients' requirements. The final part of the process is when the blood is transfused to the patient. The whole process of the supply chain is governed by very strict EU regulation, which has been incorporated into UK law as the Blood Safety and Quality Regulations, and this requires full unequivocal traceability of each component. A quality management system must be in place to ensure the safety of each of the blood products. As mentioned, the collection and processing and testing of blood products is heavily regulated. There is a strict medical selection criteria for donors, which is intended to exclude anyone whose blood might harm the recipient, for example by transmitting an infection, and it is also equally important to ensure that no harm can come to the donor. To be a volunteer donor, you have to be fit and well, have a minimum weight of 50 kilograms, be at least 17 years old. There is no upper age limit to donate regularly, however you have to be fit and well and you are assessed at each individual visit. You must have a haemoglobin of at least 13.5 grams for males and 12.5 for females. Donors donate 3 times each year, where 450 ml is drawn to make up a unit of blood. The recipient's safety is equally important to ensure that no harm can come to them. Many donors are not selected because they may have medications which they take to treat illnesses that they have, so they will be rejected. Any donors who have had cancer, with the exception of basal cell or cervical cancer, autoimmune conditions, chronic infections, a recent endoscopy procedure, if the recipient has had a transfusion, Since 1980, they are not allowed to donate as a variant CJD precaution. Some other exclusions apply to donors, and that includes things like pregnancy, cardiovascular disease and epilepsy. Each donation is tested to determine the ABO group and the RHD blood group. Further screening is undertaken, including direct antiglobulin testing, which is sometimes referred to as a Coombs test. Every donation is tested for the evidence of hepatitis B and C, HIV 1 and 2, human T-cell lymphotrophic virus, which is linked with certain types of T-cell cancers, and syphilis. For platelet donations, these are cultured before release to the local hospitals to ensure that there's no potential bacterial contamination, which can cause potential harm to the recipients. This part of the session will focus on the main blood components, products and derivatives. It is easy to understand what a blood component is. However, products and derivatives can sometimes cause confusion. The definition for a blood product and derivative is any therapeutic substance prepared from human blood. Red cells are leukocyte depleted and stored in optimal additive solution and are most commonly used red cells today. Optimal additive solution contains SAG-M, which consists of saline, adenine glucose and mannitol. This helps to maintain the red cell function and viability. It reduces the hematocrit and it replaces the removed plasma, which in turn stops the red cells from being too viscous. The hematocrit is the volume percentage of red blood cells in the blood, and it is normally around 45% for men and 40% for women. So a pack of red cells has a slightly higher hematocrit. Red cells have a shelf life of 35 days and must be stored in a validated blood refrigerator within a temperature range of 4 centigrade plus or minus 2, but ideally 4 centigrade. There is only one recognised indication for use for red cells, and that is to increase the oxygen carrying capacity of the blood. Red cells need to be ABO and RHD compatible to the recipient, and these can include special requirements, for example, CMV negative or irradiated blood, fresh or washed or PD packs. This will be discussed later in the presentation. The next two slides will give an overview of component specification for neonates. The most important issues to think about are the reason for the request and if it's appropriate. If so, the next step to consider is the transfusion a small volume, top-up transfusion, or a large volume to cover a procedure, for example in theatre. If it's a small volume, then the age of the blood is less important and units can be used up to the expiry date. If it's a large volume, then fresher blood is required. Up to 7 days post-donation should be used. This is to ensure that potassium levels within the unit are kept at a safe level for the neonate. The closer the unit is to expiry, the more potassium leakage from the red cells occurs, which could be harmful to the neonate. As the previous slide stated, the need for cross-match depends on the age of the infant and the volume required. Infants less than 4 months old rarely produce atypical red cell antibodies, with the exception of those who have repeated large cell volume transfusions. It is only under these circumstances that a repeat antibody screening of the recipient is advised and should be carried out. All requests for non-top-up transfusions must be matched with the patient's plasma. Patients who are over 4 months old must be matched to a fresh sample each time. For exchange transfusion of neonates, red cells should not contain additive solution in the unit. Alternatives that can be used are whole blood should be used, although the hematocrit may be a bit low at 0.35 to 0.45 per unit. Partially packed plasma reduced cells with a hematocrit of 0.6 or packed cells with whole blood with all but 80 ml of plasma removed, which has a hematocrit of 0.75. This could be a viscous product and that should be taken into account. Any blood used must be compatible with the maternal antibodies, so that the cross-match must be against the maternal sample. Group O, less than 5 days old, blood which is CMV seronegative, irradiated, given through a blood warmer, should be used. The volume would be between 80 to 160 ml depending on the indication for the infant. High hematocrit units can be diluted with saline and albumin, and this is usually undertaken by the laboratory. Moving on to platelets. Apheresis platelets are collected from one donor by means of an automated cell separator machine. Blood is taken out via a needle and centrifuged to separate the cells. Platelets are collected and all other parts of the blood are returned to the donor. This is usually undertaken by very motivated donors who would donate platelets every 3 weeks. Random donor platelets are processed in the blood transfusion centre. They are collected from a unit of whole blood after separation into the individual components, and 4 individual units are pooled together to make an adult donation. Therefore, each adult dose will lead to multiple donor exposures for the recipient. Platelets may contain small amounts of lymphocytes, and therefore all platelets are irradiated and are screened for the CMV status. Platelets are suspended in 40 to 60 ml of plasma. In most hospitals, only experienced haematology and blood transfusion medical staff are authorised to request platelets for a particular patient. When storing platelets, it is essential that they are kept at room temperature, as they are harmed by the cold. This can lead to a greater risk of bacterial growth and contamination at the time of donation and in the storage process, although, as previously mentioned, bacterial alert detection has significantly reduced the risk for the recipients. Extra vigilance should be taken for inspection of the product to ensure that no bacterial contamination at the time of administration by undertaking a visual inspection of the bag and monitoring the recipient. Platelets have a shelf life of 5 days. Platelet refractoriness is defined as repeated failure to achieve a satisfactory increment following platelet transfusion. This usually occurs in patients who have had multiple transfusions of platelets. Possible reasons for this include splenomegaly, which is an increased proportion of transfused patients. The platelets are pooled within the spleen and therefore cannot contribute to hemostasis. DIC, where the platelets are consumed during the activation of the coagulation mechanism. Some drugs may sensitise the platelets, which then leads to an accelerated rate of destruction. Bone marrow transplant patients, particularly those with graft versus host disease, cytomegalovirus virus infection or veno-occlusive disease. The presence of platelets autoantibodies in immune thrombocytopenia, and the presence of platelet alloantibodies including HLA and HPA antibodies. The efficacy of platelet transfusion should be monitored using clinical and laboratory parameters. If this is not the case, you should seek advice from your local transfusion laboratory, who in turn will contact the Scottish National Blood Transfusion Service and will investigate the patient and identify the problem. Moving on to fresh frozen plasma. FFP is prepared from leukocyte depleted anticoagulated whole blood, which has been collected by apheresis or donation and is then rapidly frozen to -30 centigrade. It is stored for 2 years following this. Although plasma must be ABO compatible, it is not necessary for the FFP to have RHD compatible with the patient. In the UK, FFP is imported for volunteer donors to reduce the risk of variant CJD in anyone born after the 1st of January 1996. FFP can also be treated to further reduce the risk of viral infection for the recipient by treating it with methylene blue or a solvent detergent process, and this will be discussed later. FFP consists of all the clotting factors listed that you would expect each litre of FFP to contain between 2 to 5 grams of fibrinogen. Storage, as said before, should be at -30 for a maximum of 24 months. FFP must be thawed before transfusing. The blood transfusion laboratory will ensure this is done before issue. However, you will have to take this into account during an emergency situation. Post-thaw, for the first 4 hours, the FFP can remain at room temperature. Following this, it can then be returned to the blood transfusion laboratory and stored in a designated blood fridge, and where it can remain for 24 hours at 4 centigrade. The transfusion standard dose is between 10 to 20 kilograms depending on the individual, which would usually equate to around 4 bags for each adult. Transfusion should be by the ABO group, as the RH group is irrelevant. Each transfused bag should be run over 30 to 40 minutes, and ideally ensuring that all bags are completed within 4 hours. The risk of graft versus host disease with FFP and cryoprecipitate is low, therefore irradiation is not required with these components. Cryoprecipitate is prepared from fresh frozen plasma by slowly thawing to room temperature at 4 to 6 centigrade. This results in a precipitate forming, which can then be separated from the supernatant and then be frozen for storage for up to 24 months at minus 30 centigrade. Cryoprecipitate is particularly rich in fibrinogen, factor VIII and von Willebrand factor in much higher concentrates than fresh frozen plasma alone. The ABO group of cryoprecipitate should preferably be compatible with recipient, but it is not essential as there are only small volume of plasma within each of the donations, thus reducing the risk of antibody-mediated hemolysis. Cryoprecipitate of any RH type may be given regardless of the RHD status of the recipient, although it is mostly RH positive products which are produced by the transfusion services. Cryoprecipitate is primarily used in the treatment of low fibrinogen levels. Other indications for transfusion FFP and cryoprecipitate are multiple coagulation factor deficiencies with bleeding and/or disseminated intravascular coagulation, single coagulation deficiency when viruses are present, thrombotic thrombocytopenic purpura. If a patient is undergoing plasma exchange, then solvent detergent plasma, for example Octaplas, is used routinely. This section of the presentation will focus on blood components and compatibility. ABO groups are named after antigens present on the red cell surface. In the ABO groups, individuals produce antibodies against antigens that are not present on the red cell surface. Thus, Group O individuals in their plasma have antibodies of both Group A and Group B, while AB individuals do not have either of these antibodies in their plasma. If red cells carrying A and B antigens are transfused to someone who has antibodies to these, then a severe immune reaction can occur, which can and could be fatal. The red cells are not compatible with the recipient. Group O blood can safely be given to all groups of patients in a life-threatening situation, as there are no A or B antigens to react with the other antibodies in the recipient's plasma. The risk of a hemolytic reaction if the patient has other atypical red cell antibodies. However, there is a risk of hemolytic reaction if the patient has other atypical red cell antibodies. However, the risk of this must be balanced against the risk of the patient insanguinating. Only 1% of the population will have other atypical antibodies. If the patient is known to have atypical antibodies, please contact your hospital transfusion laboratory immediately for advice, as this could delay the availability of the blood. The RHD system is the second most important blood group system, since the RHD antigen is highly immunogenic. Both types can be categorised by either RHD positive or RHD negative. Individuals with red cells which lack the RHD antigen are RHD negative. In the UK, approximately 85% of the population are RHD positive, with the other 15% being negative, although the incidence varies between different ethnic groups. Being RHD negative is usually only significant during pregnancy. If an RHD negative woman is pregnant with an RHD positive fetus, she may have potentially harmful immune response resulting in the formation of anti-D antibodies. Following the exposure of RHD positive blood, an RHD negative mother can make immune anti-D, and this can cause hemolytic disease of the newborn or severe fetal anemia and heart failure in subsequent pregnancies. Although giving RHD positive blood to an RHD negative patient will sometimes induce formation of anti-D, this does not cause any acute problem for the patient and will be picked up by the laboratory the next time the blood is processed. RHD negative blood would then be issued. For platelet selection, it is not always possible to issue platelets, fresh frozen plasma, cryoprecipitate, which are exactly the same group, to the patient. In the UK, for example, only Group O and Group A platelets are routinely produced. A small amount of incompatible plasma does not usually cause any problems for the patient, as the antibodies are diluted in the patient's blood volume and only a small amount of antibody is present to bind to the patient's red cells. Usually this does not cause an immune reaction that is seen with the transfusion of incompatible red cells. Group O plasma and platelet components should be given to Group O recipients, as often these contain high levels of antibodies, especially anti-A, which is most commonly found in Group O donors. High levels of anti-A and anti-B can cause acute hemolytic reactions to the recipients. For patients who are Group AB or AB, however, the components of a different group may be acceptable, as they do not possess high titers of anti-A and anti-B activity. Therefore, in order to prevent this hemolysis, Group O plasma donations are tested for high levels of anti-A and anti-B antibodies. Although plasma must be ABO compatible, it is not necessary to select FFP, that is RHD compatible, with the patient. Plasma components, fresh frozen plasma and cryoprecipitate, are relatively common causes of acute transfusion reactions, including allergic reactions and life-threatening anaphylaxis. High titers of antibodies in the plasma may cause hemolysis and acute lung injury in the recipient. FFP for emergency use is usually Group AB, as there is no antibodies within the plasma that can react with the patient's antibodies. Pre-transfusion testing for neonates. In a neonate, it's important to remember that red cell antibodies are derived from the mother and they are not made by the baby. Both the maternal and neonatal samples should be sent whenever possible to the transfusion lab to ensure that the blood is compatible with any antibody, be it an ABO or an atypical in the maternal and neonatal sample. If an inadequate baby sample is sent and there is no maternal sample, then the lab testing will be suboptimal. Staff should make sure that they are diligent when maternal and neonatal samples are being taken and labelled, as this can frequently lead to samples being mixed up with wrong identifiers being placed on the sample tubes. In older children, pre-transfusion testing is the same as it is in adults. Blood components and specific specifications. Some groups of patients with specific risks from transfusion have additional requirements when receiving red cells, for example, irradiated or CMV negative components. Local depletion of red cells was introduced in 1999. This involves the whole blood being filtered prior to separation into its individual components. The blood services undertake quality tests to ensure that local depletion is effective. The results that would be expected are that greater than 99% of the components should have less than 5 × 10⁶ residual leukocytes per unit of the red cells, with more than 90% of the components that are quality tested containing less than 1 × 10⁶. Local depletion reduces the risk of the patient having febrile transfusion reactions, transfusion transmission of cytomegalovirus virus, transfusion-associated graft versus host disease, HLA sensitisation, and should reduce the risk of variant CJD. For transfusion graft versus host disease, it has not been fully proven. However, new guidance from the Advisory Committee on the Safety of Blood in Tissues and Organs, SABTO, is discussed later in the presentation. Other safety procedures that have been implemented include pathogen inactivation. The addition of methylene blue in the presence of white light inactivates all lipid-enveloped viruses, including Hep B, C, and HIV, but other viruses are unaffected by this treatment, for example hepatitis A. Methylene blue is then subsequently removed by filtration at the end of processing. Commercial products are available, for example Optiplas, which is a solvent detergent process, is also available in the UK and is made from pools of more than 1,000 donors at a time. The filtering process leaves 30% less factor VIII than untreated FFP, so unfortunately filtering does remove some of the good bits as well. Moving on to irradiated blood components. These include red cells, all platelets and granulocytes. Gamma irradiation inactivates the donor T lymphocytes remaining in the blood donation, ensuring that they are unable to engraft in the recipient following the transfusion. If an immunocompromised patient receives red cells, platelets or granulocytes that have not been irradiated, the donor's T cells can cause graft versus host disease in the recipient. This in turn can lead to tissue damage, organ damage and possibly death in 90% of the cases. The types of patients who require to have irradiated blood are bone marrow and stem cell transplant patients, be this from an autologous route, cells from their own self, or from an allograft, which is cells from a volunteer donor, be that a relative or an unrelated donor. There is guidance on how long irradiation should take place. Remember to take cognizance of local guidelines as they may differ from the national guideline. All decisions to transfuse must take into account the clinical findings as well as laboratory results. Each hospital must have robust systems in place to ensure that patients who are at risk of transfusion-associated graft versus host disease receive irradiated blood components. Around this area there is a need for education on special requirements within this speciality, as it is the responsibility of the practitioner requesting the blood component to notify the hospital transfusion lab if the patient needs special requirements. Equally, it is important to remember that the patients who require irradiated components may be nursed or admitted to other departments who wouldn't regularly treat these patients. Other types of conditions or treatments that require irradiated blood are patients receiving specific chemotherapy, for example purine analogues, patients with Hodgkin's disease who require to have irradiated blood indefinitely, all granulocyte transfusions, aplastic anemia patients, all products that have been donated from relatives, immunodeficiency disorders, of which there are many different types, for example severe combined immunodeficiency or DiGiorgio anomaly, for intrauterine transfusions and large volume transfusion of neonates within 5 days of donation and 24 hours of irradiation. Informing the patient is very important. In undertaking this, you are giving the patient information on the special requirements, which is important so that they understand why they require irradiated blood, but equally it can be important that on occasions the patient will identify that they require to have irradiated blood. There are stickers contained in the patient information leaflet, and these should be inserted in the appropriate alert sections of the patient's case record. CMV negative components are produced from donations that have been specially screened for cytomegalovirus by serological techniques and have found to be negative. It is important to realise that not all irradiated products require to be CMV seronegative. CMV seropositive irradiated products are also available and should depend on the patient's status as to which they are given. There are questions around leukodepletion reducing the risk of CMV, but this has not been proven. However, there has been new guidance from the SABTO committee, which is discussed in a later slide. So what is cytomegalovirus? It is part of the herpes family of viruses. As most of the other herpes type viruses, once you're infected with CMV, it will remain inactive in your body for the rest of your life. CMV causes few symptoms in most people and is one of the most common viral infections. It is usually spread through bodily fluids such as saliva, and it can be estimated that around half of all UK adults have been infected by CMV. Most people develop the infection during early childhood or as a teenager. Unlike many viral infections, CMV usually causes few symptoms, if any. Most people do not know they've had the infection. However, CMV can be more serious when it develops or occurs in certain vulnerable groups of people with weakened immune systems, particularly those following bone marrow transplant, unborn and newborn babies. If suppression of the immune system leads to reactivation of the virus, the new infection can lead to severe multi-system disease and can often lead to death. Treatment is with antiviral drugs. Patients at particular risk of CMV are patients treated with the immunosuppressive drugs, for example Campath, allogeneic stem cell transplantations and bone marrow transplant patients, premature neonates in the first year of their life, weighing less than 1,500 grams with CMV negative mothers, all intrauterine transfusions, all patients undergoing autologous peripheral blood stem cell transplants. Care is required for this type of patient to minimise the risk of contact from individuals excreting the virus. It is important to ensure that they are not given positive blood products when they are seronegative. Routine screening is usually carried out within high-risk patient groups. As mentioned before, the Advisory Committee for the Safety of Blood, Tissues and Organs, SABTO, a committee which advises the UK Government Ministers and the devolved administrations, as well as the UK Departments of Health, on the most appropriate ways to ensure blood safety of cells, tissues and organs for transplantation. New guidance has been issued and it states that the following groups of patients should receive cellular blood components from donors which are negative for the CMV antibody. Immunocompromised CMV seronegative recipients, CMV seronegative allograft recipients receiving a CMV negative graft, CMV seronegative bone marrow autograft recipients, all patients with an acute hematological malignancy until their CMV status is known, and all CMV negative acute leukemia patients prior to transplant. Recipients of an intrauterine transfusion, pregnant females and neonates and infants in the first year of life. To summarise this presentation, it is important that you ensure you know the appropriate blood component to choose. Make sure that you document your reason for transfusion. When requesting, ask the question, does the patient require special products, for example, irradiated blood or CMV negative? Thank you.